solid tumors and oncology at the end of the day on a long day, but we'll try to make it interesting. And my goal here is to highlight topics I think are likely high yield for board testing. Um, Obviously, not going to cover all solid tumors. Is there's so much, a lot of the stuff like all the new, what drugs you can use. I just don't think that's most of it is not going to be board testable because things change so quickly. And even if it is, it's just overwhelming. Full disclosure, as you all know, I'm not an oncologist, but I did try to pick through things that I think are higher yield, or maybe some things that that are very likely to the types of things to be asked. But there's so many things we could also include here that I'm not. And I don't cover someone like I don't cover breast cancer, for example. I just try to cover some of the other solid tumors and things that hopefully we can give you something useful. Okay, a 50-year-old man presents with a bulge in his left scrotal area. He has noticed it for the last 3 days. Exam reveals a left varicocele. Hemoglobin 15, hematocrit 45, UA 10 to 30 red cells. What is most likely diagnosis? Renal cell cancer, renal vein thrombosis, prostate cancer, inguinal hernia, or a DVT? Yeah, so the right answer here is renal cell carcinoma. In this, it's not a common uh, thing that happens, but it's one of those things that when somebody gets an acute varicocele, most people are, they develop early in life. So a 50-year-old who didn't have a varicocele, now he has a varicocele, thinking about renal cell cancer. Certainly with the 10 to 30 red blood cells might suggest that as well. So now I'm not sure B is a great distractor because in people with renal cell cancer, sometimes they can also get thrombosis with the tumor that's invading. So I'm going to certainly give people credit if they chose B, but I just want to make sure you're aware of that one paraneoplastic syndrome we see with renal cell cancer. So 2% of 2% of males with renal cell cancer and 0% of women with renal cell cancer develop an acute varicocele. Um, Fever, that's a little more common, and it's one of the few cancers that can cause fever. We think about hepatocellular carcinoma can do it, renal cell cancer can do it, and certainly we think about it all the time with lymphomas. Acute hypertension, super, super rare, but it has been described. Erythrocytosis, and this gets talked about a lot, but it's only 3% of renal cell cancers that get erythrocytosis. What's much more common with renal cell cancer is actually anemia, where I think a third of patients who present with renal cell cancer have an anemia. But boards sometimes like to test these little rat facts, like because it's affecting the kidney, it can actually stimulate erythropoietin, and you get erythrocytosis rarely. One that's more common, and I've seen with renal cell cancer, and it's fascinating, is non-metastatic hepatic dysfunction, where they will get elevations in their transaminases, their alk phos may go up a little bit, and when you remove the tumor, all of that normalizes. Because when you first see it, you think they must have mets in the liver, but when you remove the tumor, the abnormalities go away. A 67-year-old man has sudden appearance of 30 lesions on his back and chest. These are new for him, no prior similar lesions. What diagnosis is of greatest concern? Here's what the lesions look like. He's got lots of these that have just kind of popped up pretty quickly when he really hadn't had much trouble with this before. Are we more worried about cutaneous lymphoma, HIV, gastric cancer, testicular cancer, or multiple myeloma? Yeah, gastric cancer. So this is a person with a sign of Les Roulotte, which is a sudden explosion of seborrheic keratoses happening very rapidly. So sometimes in people who've never had them before, or people who had just a few and suddenly they got a lot. And it's most commonly associated with GI cancers, with gastric cancer being the most common of them. So, yeah, GI adenocarcinomas, especially gastric cancers, non-Hodgkin's lymphomas, and then other rare malignancies. But think about, yeah, gastric cancer as you did. A 48-year-old woman with metastatic breast cancer reports she has been unable to use her fingerprint log for her cell phone and has been unable to do the same at the fitness center she is a member. Which of the following drugs has she been treated with that explains this? So, which of these drugs would explain her inability to have her fingerprints work anymore? Uh, Imameclibib, capecitabine, doxorubicin, eribulin, or carboplatin. So, which of these do you think it is? Yeah, the right answer here is B. Capecitabine can cause loss of fingerprints, and it's actually not that uncommon. 20 cases reported in literature in one study, um, but when they looked at it, prospectively, they found 14%. All had hand-foot syndrome. Loss of fingerprints was not associated with severity. So some of them had mild hand-foot syndrome, and they just picked it up when they looked for it. So kind of an interesting side effect here. The 64-year-old gentleman with a 60-pack year history ongoing tobacco use presents to clinic with progressive weakness. He's alert and oriented times 4. Temperature is 37.4. Uh, blood pressure. I'm actually going to move this out of here. Blood pressure is something. O2 sat 92% on ambient air. He has no lymphadenopathy. He has proximal muscle weakness in the lower extremities with absent reflexes. He on X-ray has a centrally located lung mass. What is the most likely cause for his weakness? Lambert-Eaton syndrome, hypercalcemia, hyponatremia, cerebral metastases, or spinal cord metastases? So this is very typical Lambert-Eaton syndrome, which is seen most commonly with different lung tumors. A 59-year-old presents with dizziness and nausea, ataxia, and 3 falls in the last 2 days. He has also had diplopia, past medical history, 75-pack-year smoking history, hypertension, and depression. He's currently on irbesartan and escitalopram. Sodium is 127, BUN is 30, creatinine zero point 0.8, chest x-ray 7 centimeter hilar mass, MRI is done of the brain, no metastatic disease or stroke. Which of the following is the most likely to be found on further testing? Antibodies to MA proteins, antibodies to antibodies, anti-WHO antibodies, or anti-YO antibodies. So which of these would fit with this presentation for this patient? So yeah, the right answer here is C, anti-WHO antibodies. And this is a patient who has paraneoplastic cerebellar degeneration. Uh, and when you look at the different tumors that cause problems, anti-Yo is associated with breast and ovarian cancer, anti-WHO with small cell lung cancer. And this patient probably has that. He's got a hyponatremia with the sodium 127, suggestive of small cell lung cancer, anti-TR associated with Hodgkin's disease, and antibodies to MA proteins associated with germ cell tumors. So just to review the neurologic paraneoplastic syndromes that we see with small cell lung cancer, which is very, very active in this, They can get Lambert-Eaton syndrome shown with loss of reflexes and proximal muscle weakness. Um, they can get peripheral neuropathy. They can get anti-WHO antibodies causing a paraneoplastic cerebellar degeneration. And they can get involvement of other parts, including the spinal cord, dorsal root ganglia, and then they can get cortical cerebellar degeneration as well. So very, very active. We always think of small cell lung cancer when we see weird paraneoplastic syndromes. An 84-year-old gentleman with 65-year tobacco use and no metastatic lung cancer on no specific cancer-related therapy due to poor performance status presents to the ED with confusion and abdominal pain. He is visiting Seattle from out of town because it was on his bucket list, and he comes with no records. You're unable to get electronic records either, but you do the basic workup, and his serum calcium is elevated very, very, very high. So his serum calcium is 12, and albumin's low, so that's much higher than that. What is the most likely cancer type as you look at this person who has known metastatic cancer? Um, which is the most likely cancer type? Small cell lung cancer, adenocarcinoma of the lung, squamous cell lung cancer, or carcinoid of the lung? Yeah, so the right answer is squamous cell. So half of you got that, which is very good. I threw this in there because this is kind of a tricky one because we sort of get ready for everything to be small cell because it's associated with so many different paraneoplastic syndromes. But the really severe hypercalcemia is squamous cell, and it could be squamous cell lung, it could be squamous cell cervical, it could be other squamous cells that are, have a significant mass of squamous cells. So as you know, it can cause a PTH-like hormone, and that is what causes hypercalcemia. So, kind of going through some of the different paraneoplastic syndromes we see with lung cancers. Squamous cell, we see hypercalcemia. We can see polymyositis, dermatomyositis, clubbing. Uh, Lung malignancies can cause clubbing. It can cause also hypertrophic osteoarthropathy, which looks a lot like clubbing. So, very common to see paraneoplastic syndromes, both lab paraneoplastic syndromes as well as clinical things we can see on physical exam and symptomatically in our patients who have malignancies. Other other paraneoplastic syndromes with small cell Cushing syndrome occur in 2 to 5%. Some of these patients don't look like Cushing syndrome. They just have hypokalemia, hypertension, and muscle weakness. They may not be fully Cushingoid. So when you see a person, who fits other things, it certainly can happen. And sometimes we see that because they're losing so much weight that even though they have increased steroid, they're not putting on a lot of the centripetal obesity or the buffalo hump or some of the facial stuff because they have so much weight loss. And SIADH is very common at 16% in these patients. A 70-year-old gentleman with a 55-year history of tobacco use and 6 months of cough and weight loss presents with 1 week of hemoptysis. Chest x-ray shows right upper lobe mass. CT of chest and abdomen confirms 6 centimeter right upper lobe pulmonary mass with mild mediastinal lymph node enlargement. CT guided biopsy of the lung mass reveals adenocarcinoma of the lung. PET CT shows large uptake in the right upper lobe mass and low level uptake in the mediastinal lymph nodes. MRI of the brain and mediastinoscopy with lymph node sampling show no cancer. Performance status is good. What is the most appropriate treatment plan for this patient? So this person has hemoptysis. He's got a right upper lobe mass, 6 centimeter right upper lobe mass, and mediastinal lymph node enlargement. We do the workup and we confirm an adenocarcinoma of the lung, and he has low level uptake in the mediastinal lymph nodes, but doesn't have it elsewhere. MRI and mediastinal lymph node sampling showed no cancer. So what do we do? Surgery with subsequent chemotherapy, or immunotherapy. Yeah, so surgery with subsequent chemotherapy, uh, based on his work up here, and this person with non-small cell lung cancer, and this person has stage 2, and it can be curative in these patients, and so we're going to want to move forward with that. So he fits surgical resection for cure, then adjuvant chemotherapy. So he's going to, fit stage 2 here. 75-year-old man presents to the ED with a 3-week history of facial swelling and headache and a 2-week history of dyspnea. He has a 100-pack-year smoking history. Blood pressure is 110/70, pulse is 105, temperature 36.8, O2 sat 92%. He has diffuse facial erythema present and neck veins are dilated bilaterally. CT shows a 9 centimeter mediastinal right lung mass and large mediastinal lymphadenopathy. Severe SVC compression is present. What is the most appropriate management? So this person's coming in with headache and facial swelling, and he's been dyspneic, and he's got facial erythema and neck veins dilated bilaterally, and he's got a very large right lung mass with large mediastinal lymphadenopathy and SVC compression. What is the most appropriate management? Biopsy of the lung mass, immediate radiation therapy, placement of an SVC stent, begin carboplatin, or begin pembrolizumab. So I think the right answer here is you need tissue. You need to do a biopsy here. And for many years we've been taught that SVC syndrome is an oncologic emergency, and I'd put it as an oncologic urgency, that in most cases it's not an emergency. And certainly when I was training in the 1980s, they told us that these people needed radiation immediately, that you just, this is an emergency, you got to do that. And more recent data has really moved us away from the immediate radiation or immediate chemotherapy, doing something that, and even immediate stenting. So, superior vena cava syndrome it can either be direct compression from tumor, it can be tumor invasion, or it can be big lymph nodes that are pressing on it. And this patient had facial sweating and swelling and headache. He had some dyspnea. He had all of the signs or symptoms. But the most important thing is find out what it is. Because if this is small cell, then you're going to do aggressive chemotherapy. You're probably not going to lead with radiation therapy. The only time that you're going to do something major is if they have true pulmonary compromise. If this person is an extreme inability to breathe, he's dyspneic, but we didn't tell you anything about him being hypoxic or being unable to breathe, or if they have true cerebral edema, then you'd put a stent in immediately. But we're going to try to make the diagnosis first because we may be able to treat this person without stenting them. Stents have a lot of complications along with this. So this is more common in non-small cell lung cancer with 50%, 25% is in small cell lung cancer, and then you can get it with other mediastinal tumors, with non-Hodgkin's lymphoma being the most common. Interestingly, uh, it's not always the cancer that does it. Sometimes it's the intravascular devices. Sometimes people will have lines in for their chemotherapy and they'll have massive clotting with that, and that will present with a superior vena cava syndrome. A 50-year-old woman of East Asian descent presents with several months of cough. She's never smoked and she has no known pulmonary disease. No nausea. Chest x-ray shows a left peripheral lung mass. CT chest and abdomen shows 4 centimeter left lung mass, hilar and mediastinal lymph node enlargement, and a pleural effusion. A CT biopsy of the mass shows adenocarcinoma. Which of the following is the most appropriate management for this patient? A PET scan, surgical resection, EGFR mutation testing, carboplatin plus docetaxel, or hospice referral. So the right answer here is C. We really have to get an EGFR. This is a high likelihood patient of having this EGFR mutation, and it will totally drive our treatment plan. And with the uh, with the hilar mediastinal lymphadenopathy and pleural effusion, extremely likely if you get a PET, all that's going to light up and more. But we're still going to treat this patient very aggressively. If they have EGFR mutation, we can get them on the right med. And this patient has a significant chance of going into remission with the right treatment. So, non-small cell lung cancers, I think it's so important for us, these adenocarcinomas, to test all these patients. And some subgroups are much more likely. This person was of East Asian descent, where we see a lot more of the EGFR mutation, and it has the best prognosis. And these people all need to get a tyrosine kinase inhibitor. And they do very, very well with it. And some of these people do very well for quite some time. 60-year-old woman with a history of metastatic melanoma presents to the ED with a 5-day history of diarrhea. She has 8 to 9 loose stools daily with some abdominal cramping. She's had no recent antibiotic use, traveler history, or history of bowel disease. She has just received the fourth of 4 doses of epilimumab therapy. Her temperature 37, blood pressure 120/80, pulse is 100, soft non-tender abdomen, but with increased bowel tones. Hemoglobin, hematocrit, white cells are okay. AST is high, ALT is high, BUN is up, and creatinine's up a little bit. Which of the following is the most appropriate next step in management? Starter on oral Vanco, GCSF, high dose IV steroids, or supportive care? The right answer here, which I think half of you chose, is high dose IV steroids. This is a patient who's fortunately just received their last dose of the ipilimumab therapy. So it's being stopped anyway, but she's now run into a lot of side effects related to it. And the enterocolitis is very, very common. All this patient also has hepatitis. They can also get pulmonary, and many of these patients can get rash as well. And it can show up a little later. It can show up with cycle 3, cycle 4. It's not always going to show up with cycle 1 or cycle 2. So when these people have the hepatitis and when they have the enterocolitis, they really need to get steroids. So we stop the drug and then we treat them with steroids. And the drug's already been stopped. So here we're left with steroids. I wanted to go over a couple of chemotherapy facts that are so common. It's important to know them. We can't memorize every chemotherapy effect because everything has multiple ones, but very classic ones: the drugs that cause peripheral neuropathy, platinum compounds, vinca alkaloids like vincristine, vinblastine, and taxanes all can cause peripheral neuropathy. Cardiomyopathy, anthracycline, cyclophosphamide, and trastuzumab, and several of the newer MABs also can do this, and can be very, very treatment limiting. 84-year-old gentleman with no metastatic prostate cancer presents with several-month history of back pain and 1 week of lower extremity weakness. No trauma. On physical exam, point tenderness over T12 vertebral body, decreased bilateral lower extremity strength, increased bilateral lower extremity reflexes, and bilateral extensor plantar reflexes. MRI of thoracic and lumbar spine shows radiographic lesions typical of metastatic prostate cancer at T12 with associated spinal cord compression. What is the most appropriate initial treatment? Radiation therapy, corticosteroids plus radiation therapy, a bisphosphonate, chemotherapy, or corticosteroids? Yeah, corticosteroids and radiation therapy is the right answer. This is a medical emergency. When people get acute neurologic symptoms with metastatic disease of the spinal cord, we got very little time to act, and whatever we can do to try to preserve neurologic function is correct. So when you see spinal cord compression, you really want to get a diagnosis today. This is not one where we want to wait 3 or 4 days. And we give steroids immediately. We go ahead and get radiation therapy as quickly as we possibly can do it. So certainly that last question said steroids and steroids radiation. Yes, the steroids might be all we can do tonight, but if we can get radiation done in the next 24 to 36 hours, that would be great. If we know it's a chemotherapy sensitive tumor, this was not, but if we know that, then probably would be adding chemotherapy as well. Most common are prostate cancer, lung, and breast cancer, these tumors that so commonly go to the spine. A couple comments about Cauda-Equina syndrome. This is another one you might get tested on. Physical exam, we look for saddle anesthesia, so we do sensory testing in the area where the butt would hit a saddle. Patients can get lower extremity weakness, bowel and bladder dysfunction, and sometimes can get radicular pain. A 67-year-old gentleman undergoes colonoscopy for bright red blood per rectum and is found to have a 3-centimeter adenocarcinoma located 8 centimeters from the anal verge. Contrast-enhanced CT of the chest, abdomen, pelvis shows no evidence for metastases. Endorectal ultrasound reveals full thickness involvement of the rectum with no lymph node involvement, T3N0M0. What is the most appropriate treatment? Is it surgery, surgery with subsequent chemotherapy and radiation therapy, chemotherapy and radiation, then surgery, then subsequent chemotherapy, or chemotherapy and radiation therapy, radiation therapy? Well, this one's, one of those hard ones because, they all sound good. They all sound like something that makes sense. And, the reality is that this person is going to need everything. And this person's going to need, this person was T3N0, I believe. So he's stage 2. So radiation and chemo before surgery and chemotherapy after surgery. So these patients get a mix of all of these, and it's just how you sequence them based on their stage. So those with stage 1, you can just remove the tumor and be done with it all. When you go to stage 2, 3, and 4, they get surgery for different reasons. Stage 4 is palliative surgery. 42-year-old HIV positive gentleman presents with rectal pain and bleeding. Physical exam reveals a 2-centimeter mass in the anal canal. Colonoscopy shows no other masses. Biopsy of the anal mass reveals invasive squamous cell carcinoma. Contrast-enhanced CT of the chest, abdomen, pelvis shows no evidence of METs. Endorectal ultrasound confirms a 2.3-centimeter mass in the anal canal with no perirectal lymph node involvement. What is the most appropriate treatment? Surgery, surgery with subsequent chemo and radiation therapy, or radiation therapy and chemo? So this is one to take note of because it's just odd. It's you're thinking, well, this guy's got a mass, we got to remove it. And the answer is no, we don't. That with these patients with anal cancers, that these patients can be cured with chemotherapy and radiation therapy. So we generally do initial combined radiation and chemotherapy with curative intent. And we only do surgery if we cannot cure them with radiation and chemo. And I have an HIV clinic. I have a number of patients who have had this entity, HPV driven, and I have yet to have a patient who's ended up needing surgery. These patients have done very well with radiation and chemo. Okay, I think this is our last question. A 34-year-old man presents with sore throat that has been present for 3 months. He was treated with 2 courses of antibiotics without improvement. On exam, he has an erythematous lesion adjacent to his right tonsil. He has a 4 centimeter anterior right cervical lymph node. Biopsy shows squamous cell cancer. What is the most likely risk factor in this patient? Tobacco use, marijuana use, alcohol use, or HPV? Okay, so the right answer here is HPV. And I put this one in because, we're always taught that when we see malignancies of the head and neck, that it's usually tobacco or combined tobacco and alcohol use. But when you see it in younger people, HPV is probably the culprit. And the response to therapy tends to be different between these HPV-driven tumors and the tobacco slash alcohol risk factors that we see in like our 60 and 70-year-olds with esophageal cancer, or 60 and 70-year-olds who have cancer of the mouth, or cancer a little bit farther back. One of the pearls here is sort of lesions right by the tonsil, and especially when we see tonsillar cancers, we're seeing a lot more HPV now. So squamous cell cancer in your older patients, tonsillar cancer, younger patients, we think of HPV. Outcomes are much better in these patients. Um, Interestingly, multiple unilateral nodes less than 6 centimeter are considered N1 disease with HPV cancers. And these patients, treatment with radiation therapy, surgery alone, or in combination with cisplatin, can be curative for these patients, especially the HPV cancer. So, kind of a very different outcome from what kind of we knew for many, many years with head and neck squamous cell cancers. The squamous cells that are tobacco related tend not to do so well. They don't have the same better outcome that we see with the HPV cancers. Okay, I lied. There's one last question here. 67-year-old gentleman presents with decreased energy, dull right upper quadrant pain, and weight loss over 6 months. Vitals are normal. Temporal wasting, hepatomegaly, fluid wave, and lower extremity edema present. Rest of the exam is normal. Chem 8 is normal. CBC with mild anemia. Albumin is low. Alk Phos and bilirubin are elevated. PSA is normal. CT of chest, abdomen, pelvis demonstrates ascites and multiple hypodense lesions replacing over 50% of the liver. Needle biopsy of the liver lesion shows moderately differentiated adenocarcinoma. Upper endoscopy and colonoscopy are normal. Empiric chemotherapy for which of the following primaries is appropriate if you choose chemotherapy here? Which of these is appropriate? Lung, prostate, testicular, or gastrointestinal? Yeah, so this is gastrointestinal. This is a carcinoma unknown primary case. And if it's under the diaphragm, we are going to assume that it's GI. A lot, we're doing better and better because we can do special stains on all these and get a lot of suggestion, but we still do see patients where it's undifferentiated enough that we have to guess. And in general, the likelihood is far greater, even with the normal upper and lower endoscopies, that the primary was gastrointestinal here. So we kind of look at the different cancer of unknown primaries, and after our workup in women with isolated malignant axillary lymphadenopathy, we will treat for breast cancer even if we don't find it in the breast. Women with abdominal carcinomatosis and ascites, I think obviously we're going to think ovarian cancer. Young men, this is not a young man, so this is an older man, but a young man with in the mediastinal retroperineum, will assume it's testicular cancer. Predominantly below the diaphragm, gastrointestinal cancers. Above the diaphragm, we'll assume it's a lung cancer. If we don't have other markers, we will do chemotherapy going towards these things. So last pearls here for this talk. Know your paraneoplastic syndromes: hypercalcemia, squamous cell cancer over small cell, no side effects of chemotherapy and immune therapy drugs, rash, diarrhea, checkpoint inhibitors, causes of neuropathy and cardiomyopathy, and know how different forms of lung cancer are treated, which ones are operated on, the ability to treat some of the non-small cell adenocarcinomas with some of the newer agents, and how we can get great outcomes with that. So we'll stop there, and I will see you again tomorrow. Hopefully you can get some rest tonight, and good job hanging in there.
Thank you so much. Fantastic as always. We'll see everyone tomorrow morning.